Hello and welcome. My name is Evan Kyle. I'm a junior at St. Thomas. I'm a biology major. I would like to thank you all for coming out and listening to my talk on tuberculosis. I'll be going through the pathophysiology, the symptoms, and the treatment of this disease. Thank you. I'll first start off by talking about what my exposure to TB looks like and why I chose this disease to do a presentation on. I was first exposed to TB on my J-term trip last year to Botswana, Africa. This is sub-Saharan, so tuberculosis is very present in this country, and I had little to no exposure before entering this country. And once I was there, I was actually able to travel to a TB clinic and learn about the disease firsthand and what that looks like. And the Coffers Point, I have a picture later at this clinic where I was in Botswana. So this first just sparked my interest, and I figured this presentation would be a good way to further my knowledge of that. So why do we care? Why do we as a country, why do we as the United States care about tuberculosis? We care because TB is actually the #1 infectious disease killer worldwide. About 1/3 of the world's population is infected with TB, and this is a latent form, so it's not active, but it is in your lungs. Those bacilli are present in your body. And here's a quote from the director of the Stop TB Partnership. "It is a global disgrace and a human tragedy that TB, a curable disease, is killing around 1.5 million people per year, and nobody speaks out about ending it." So this alone is enough to care about this disease, enough to research this and figure out why this is happening. And this Stop TB Partnership is about 1,300 people, 1,300 partners worldwide, and they are transforming the fight against TB in about 100 countries. They have goals by 2015, so this year, to lessen the global burden of TB disease, so the prevalence and deaths to be reduced by 50% from the 1990 levels. They also have another goal farther down the road in 2050 that the global incidence of TB will be less than 1 per million population. So elimination of TB as a global health public problem. And big organizations like the WHO, like this partnership, are fighting to end this disease, but is it enough? So here's a little information about what this Mycobacterium tuberculosis actually looks like, shortened as MTB. So MTB is a rod-shaped bacteria. It's very small, so it can actually infect the alveoli of the lungs. So that's way down deep through the bronchi, through the bronchioles, to the alveoli. That is in pretty much direct contact to the bloodstream. So that's very dangerous as we're looking forward. It's a slow-moving bacteria in the sense that it reproduces about every 15 to 20 hours. So it will take a while to get that presence up. It has a waxy coating on the surface and can appear both gram-positive and gram-negative, which makes it sometimes hard to diagnose. And then properties about the disease is another story. So about 10 million new cases a year have been documented over the past couple of years. Death rates have dropped 47% from 2000 to 2014, which is huge. And again, 1/3 of the population is still infected with latent TB. The strain can lay dormant for months to even decades. So a question we're going to ask and hopefully answer through this presentation is, how does the disease present itself in both latent and active forms? So there are actually 3 possible outcomes once you are exposed to Mycobacterium tuberculosis. The first is that the bacteria enters your body. The macrophages in your lungs on the lining will engulf the pathogen. This is all ideal, so the macrophages will actually kill the pathogen. We'll talk about how that works. And then the body stays healthy and uninfected. All of the bacteria is taken care of, and you're healthy. The second outcome is actually that latent TB that I was talking about. So again, the bacteria will enter your body. They will move all the way to the alveoli at the ends of your lungs. The macrophages will engulf the pathogen, but it turns out in this form that macrophages aren't actually able to keep up and kill all the pathogen that enters and proliferates within your lungs. So the body, to combat this, and we'll go into this deeper later in this presentation, but the body will form a granuloma around the bacteria. So basically it'll just encapsulate and store it, so the bacteria cannot proliferate, and they just stay in this form in that granuloma. So then again, the body will stay healthy, although still infected with the disease. So the third possible outcome, once you are exposed to TB, is that the bacteria enters the body, those macrophages engulf the pathogen, and the macrophages are actually unable to kill the pathogen. Again, in this one, the granuloma is not formed, so that encapsule around the bacteria is not formed. Or another part that would go under 4 as well, is that the granuloma is destroyed. So the granuloma forms at one point, but then perhaps your body is infected with something else or is immunosuppressed for some reason, maybe HIV or just aging. Then the granuloma cannot keep up. Those macrophages cannot keep killing off that bacteria. So you will become infected, and the bacteria begins to proliferate and replicate. So what that is going to look like, we'll get into in a second. So now we're actually going to get into the pathogenesis of tuberculosis. So what it looks like when a person is infected, what happens once that bacteria enters your body. So a few questions we're going to answer is, how is tuberculosis transferred from person to person? What happens when MTB enters into the lungs? How does the body control the infection, and how does the bacteria attempt to evade the immune system? So we're going to first answer that first question: how is MTB transferred from one person to another, from an infected individual to someone that is uninfected? So it is spread by the small bacilli ejected from one person from their lungs when they either cough or sneeze. These bacilli need to be inhaled by an adjacent person, so someone that's in the room, someone that's close. And the bacilli, again, they're carried by water or mucus droplet that is ejected from the person, as shown in this picture. And yeah, so this is actually not spread by shaking hands or sharing drinks or actually kissing, because these bacilli do need to be inhaled by someone who's uninfected. They need to be inhaled into the lungs for this bacteria to begin growing. So I'll now talk a little on that initial exposure. So what happens once the bacteria enter your lungs? So they'll actually move from your trachea to your bronchi to the bronchioles and all the way to the alveoli. So that's where your lungs are in close contact to the bloodstream. This is where oxygen is taken up. The bacilli in the lungs will be coated with complement proteins, so with C through B and others, that increase the chances of them to be engulfed by macrophages. This happens to a lot of bacteria that enter the bloodstream. And then, yeah, those local macrophages they are the initial responders. So they will engulf the pathogens as they recognize them as non-self. And we'll talk a little bit about that as well. But they are attracted to the complement proteins. They're attracted to the mannose sugars present on the bacteria, and they're going to begin to engulf them. So once that happens, once these bacteria are engulfed, they'll be brought into the macrophage and within a vacuole. And hopefully, if the bacteria is not able to evade this process, the macrophage will induce an acidic environment and other reactive nitrogen intermediates to this bacteria by forming a phagolysozyme interaction. And this happens by that vacuole being formed with a lysozyme within the bacteria, and that process will begin to kill the bacteria within the macrophage. And then broken down bacteria will be presented on the MHC class 2 to the outside of the macrophage, and this will begin many processes as shown in this figure. Actually shows what happens once a macrophage breaks down a bacteria within it and begins to present it on that MHC class 2 to a T helper cell, one that is CD4 positive. And we'll get into what happens when the T helper cell gets that signal and what other signals it's going to give off to actually call on other cells to help the infection. So now I'll talk a little bit about what happens when that T helper cell gets activated and how it does that. So the presenting cell, namely the macrophage, could be a neutrophil, could be a dendritic cell, will begin to secrete IL-12 once it does recognize that it has engulfed a non-self cell. And this IL-12 will go to activate a T helper cell. It'll give it that second signal as shown in the last figure. This occurs about 2 to 6 weeks after the infection occurs, so after that initial exposure. So that T helper cell, which is CD4 positive, is also activated by the presentation of that activated macrophage, as we showed in the last slide. That MHC class 2 will present that broken up bacteria to the T helper cell, and the IL-12 will act as the second signal, and this T helper cell will become activated. So what that looks like, once the T helper cell is activated, it'll begin to secrete two things, IFN gamma and IL-2. These will go to activate new macrophages, ones that have not come into contact with the bacteria, and actually will call them to the site of infection. We'll call them closer to the source of the bacteria. And all of these macrophages, which are called to the site, will begin to form a granuloma. And this is shown on the left. A granuloma is just basically a ball. It's wrapped around the bacilli that are in the body. So these macrophages will be engulfing them, but they will just place more and more layers on top of them, including a couple T helper cells, along with a couple other cells, to just enclose these bacteria and close them off, give them low oxygen, and not any food that they can feed off of. So this will eventually, hopefully, cause the bacteria to eventually die off. So I'm going to get into talking about the properties of a granuloma and what it looks like and what it does for our diagnosis of tuberculosis. So the activation of these macrophages lead to a substantial release of lytic enzymes. So lytic enzymes are ones that participate in lysis. They're involved in cell program death, so cell necrosis, and they destroy, unfortunately, nearby healthy cells within the lungs. They actually form a lesion with a causaceous center that we'll be able to see on an X-ray as that center begins to heal, as those cells begin to harden and callus. We'll be able to see that on the X-ray as shown on the right. And this accounts for much of the tissue damage from tuberculosis, actually. So as that bacteria begins to proliferate, those macrophages come to the site, and these lytic enzymes will begin to, unfortunately, hurt healthy cells around it. And just going into what a granuloma actually does, with a healthy immune system, the bacteria can stay within that latent phase because we form this granuloma, that baseball, that circle around these bacteria. So when the immune system is high, these bacteria stay at bay. They have low oxygen and a very high acidity within that granuloma. So we'll keep these bacteria in a latent form. But then again, if the immune system is compromised, we've talked about this, if the patient has HIV, if they're immunosuppressed for any other reason, if they're aging, even if they have malnutrition, all as shown on the right, that their immune system will be compromised. That will lead to these granulomas not being able to keep up with those macrophage production in that acidic environment. So the tuberculosis will actually burst out and begin to proliferate within the lungs. These granulomas that I've talked about, these all occur when the immune system is in full force and is working properly, but it's often found that these bacteria try to avoid being killed for obvious reasons by two main functions, which I'll talk about. So the first is by inhibiting the formation of those phagolysosomes within the macrophages. So the phagolysosomes, again, they introduce that acidic environment, and if that acidic environment is not there, these bacteria are actually able to multiply. Even if that granuloma is formed around them, it actually gives them an environment that is warm, that is has nutrients, and actually can proliferate to the point of bursting within that granuloma. So they try to inhibit the formation of the phagolysosome. And also, if that phagolysosome is formed, the bacteria actually can release sulfatides and ammonium to neutralize the acidic environment. And again, they can proliferate within that granuloma, and then they begin to multiply to the point of that granuloma bursting. So even with that granuloma, some bacteria may lay dormant and not be killed, even if that phagolysosome is formed. So these bacteria can lay dormant in the granuloma and for many years without proliferating, and just wait until the immune system is low and that they can begin to proliferate and take over. So now I'll briefly talk about what the symptoms of tuberculosis are. So what are the signs of an infection, who can transmit the disease, and what the treatment options are for both short-term and long-term. So if TB begins that active form, if it is proliferating, a lot of symptoms will include the following. So fevers and chills, unexpected weight loss is often mentioned with tuberculosis, and has been studied to show that people who do have that unexpected weight loss are at more risk for death by tuberculosis. There's been shown that night sweats is a big problem, excessive coughing, which can induce the spreading of tuberculosis, bloody sputum from these lesions within the lungs, and chest pain. And this potentially could be because tuberculosis has spread across the body. So if the body is not able to contain the tuberculosis within the lungs, within those granulomas, TB will begin to spread through the bloodstream to places like the bones, which can lead to joint destruction and pain. Could spread to the brain, which can cause meningitis. Could spread to the liver and kidneys and impair their filtration functions, and lead to bloody urine. And another one that is common as well is can affect the heart and impair the heart's ability to pump blood, resulting in a condition called cardiac tamponade that can be fatal. So who can spread this disease? I'll mention that only people with this active form can actually spread it. So if you are in that latent form, you may not know that, and it's nice that you can actually not spread that unless you're in that active form when you're showing these symptoms. In this picture on the right is actually a picture that I took when I was in Botswana. This is quoted a cougher's point. So someone that has a coughing fit, that excessive coughing, is actually instructed to go, once they're in this TB clinic, to go to this place and just cough to the point when they're done, so they're not going to spread that disease to everybody around them. So now I'll talk a little bit, once those signs are recognized, what the treatment options include. So TB is first diagnosed with most commonly a skin test, or potentially a blood test, a sputum test, or a chest x-ray to look for those lesions that have begun to calcify. So once TB is diagnosed, the treatment of the disease depends on, one, the strain of the disease. So if it's resistant to any drugs, then two, the person's age, health, gender, where the infection has taken place. So if it's spread to the lungs, past the lungs, to the heart, to the bones, wherever that may be. Then an antibiotic is often required for multiple months. So it's usually taken 6 to 9 months. And if it is a multi-drug resistant or drug resistant, multiple drugs will be needed to be used. So it's not just one, but it's multiple throughout the course of many months. So once that person first comes in and is actually diagnosed with tuberculosis, it's important to take care of those initial needs. So giving them any fluids that they need, giving them any pain medication. But once it is diagnosed, it's important to get them started on antibiotics immediately to keep those bacteria at bay, to decrease that number. So this happens with isoniazid and rifampin. These are two very good drugs as shown in this picture for targeting tuberculosis. So the first line of treatment is the isoniazid and rifampin. These two drugs are given almost immediately once diagnosed with tuberculosis. And then once the strain is identified as either multi-drug or X-drug resistant, other treatment options will need to be taken. These treatment options for a multi-drug resistant strain of tuberculosis include fluoroquinolones, among many others. As shown on the left, there's many injectable drugs that can be given, many antibiotics that can be given to target this bacteria in different ways. And then on the right is the X-drug resistant. So X-drug resistant needs a third line of attack. So these second line and the first line are all blocked. They are all resistant in this strain, and they need to be taken by different drugs and multiple of them for multiple months, as said previously. So the options are out there, but they are limited as the strain of tuberculosis becomes more and more resistant. So over time, tuberculosis has become more and more resistant to these drugs that we've been giving them. And this stems from individuals, when given these drugs, are not taking them on a daily schedule. They're not taking them every day, and this leaves time for the bacteria to begin to become resistant. So high regulation is needed when these drugs are being administered. Drugs need to be taken every day for many months so the bacteria have zero time to become resistant. So now I'll just briefly talk about an overview of tuberculosis. So first, it is spread through the coughing of an infected individual and the inhalation of these bacilli by a person that is not infected. These small bacteria will travel to the alveoli and begin to elicit an immunological response. The macrophages will engulf the bacteria and form a phagolysosome within that macrophage to begin to kill the bacteria. If the bacteria cannot be killed immediately, T helper cells will be activated and more macrophages will be brought in to help inform that granuloma to enclose the bacteria. And then if the immune system is not compromised, that latent state of this bacteria will stay potentially indefinitely. But if the immune system is compromised by multiple reasons, the bacteria could begin to proliferate. And once that proliferation occurs, the bacteria hopefully are recognized and diagnosed, and treatment can be begun. So I'd like to thank you guys all for coming out, listening to this talk on tuberculosis. If you have any other questions about tuberculosis, there's a lot of information online through the World Health Organization or through the National Institute of Health, or even that Stop TB partnership that I was talking about. They've put out a lot of information, a lot of infographics about what TB looks like across the nation and across the world. Just encourage all of you guys to continue to research this subject, as it is a pressing matter. 1/3 of the world is infected, and about 1.5 million people die each year from this disease that is curable. So I'd encourage you guys to look and search for what we can do from our perspective to help the stop of tuberculosis.